Thank you all so much for the invitation to come and speak with this group. It's nice to see some familiar faces in the audience as well. So just a little bit about me. I work at Children's Hospital Colorado, where I direct our multidisciplinary asthma clinic. And so that's our clinic for patients with difficult to treat or severe asthma. And the reason we call it multidisciplinary is because we have so many great services working with us, one of which is our dietitians to talk about nutrition. And so today, this concept of asthma and obesity comes up fairly commonly in our clinic, and that's where I'll kind of draw from some of my experiences as we move ahead. All right, here's my disclosures. So our objectives today are going to be recognize this both symptomatic and causative interplay between obesity and asthma. But I also want you to realize that this is just not a disease of weight or size, but also a disease of inflammation. And that subsequently determines our treatment options that we're going to talk about, and even some of the more exploratory ones that we may start using in the future. All right, so I'm going to start out with something a little fun. Does anybody know what an autostereogram is? All right, if anybody was alive in the 90s, do you remember these magic eyes? That's an autostereogram, okay? So you look at it, it looks at like a two-dimensional picture, but then there's a three-dimensional picture underneath. All right, not to get anyone sick, but let's see. Can you tell me, does anybody see what the image is here? And if you do, feel free to shout it out. You see leaves, but can you see through the leaves to what is underneath by any chance? It's a horse, if you can see it. So you just kind of let your eyes kind of like go numb, stare through the picture and everything. So the reason why I bring this up is because I think when a lot of us think about obesity and asthma, we look at it at a two-dimensional level. We think about it as clearly this child has obesity, it's going to make it harder for them to breathe, and we kind of chalk it up to that. But as you learn more about this, this is a very unique underlying phenotype that requires unique treatment with it, and so I want you to take today to look beyond the 2D picture to see the 3D level. All right, so we're all well aware that asthma symptoms are worse in those patients who do have obesity. There's been several studies out there that have shown that they have longer duration of symptoms after getting sick. They have increased sputum production, more nocturnal symptoms, increased dyspnea or shortness of breath, and lower quality of life. In addition, these patients are more frequent healthcare users. So they're going to have more ED visits, more hospitalizations, and when they do get hospitalized, they're at an even increased risk for mechanical ventilation. So that could be BiPAP or intubation along the way. They're also more likely to be prescribed steroids for exacerbations than their normal weight counterparts. So this is another way, as we'll see, that potentially steroids could actually be aggravating the situation that's happening with asthma. All right, so this was a study that was done of pediatric patients where they categorized them into three different categories: normal weight, overweight, and obese. And they all had asthma, and they followed them over the course of a year. And then they checked back 1 year later and said, how does your asthma compare to where it was at the baseline at the start? And what you can see here is highlighted by the blue bar, which is the obese patients. These patients had worse symptom scores, worse exacerbations, worse quality of life overall than their normal or overweight counterparts. So this once again is illustrating it's not just in adults but also in the pediatric population. It's not just exacerbations but how it affects them on a day-to-day basis. So now that we know that obesity worsens asthma symptoms, let's talk a little bit about how the two may be connected in terms of development of disease. So this was a study of pediatric patients where they looked at them and said, if you are obese or overweight, are you more likely to develop asthma or develop wheezing? And what you can see here is that if you had either obesity or wheezing, you were more likely to have both. You were 30% more likely to develop asthma, 90% more likely to be wheezing. If you were obese, it was more pronounced than if you were overweight, with about an increased 40% increased risk of developing asthma if you're obese, and a 22% increased risk if you're overweight. They also found that that this was significantly higher in girls than in boys. I'm not sure exactly why that was the case, but that's what we saw in this study. So clearly, just having obesity alone makes you more likely to wheeze, more likely to have asthma. So there's some concept that also your asthma affects obesity. So let's think about this. So if you are having exercise-induced symptoms and you're having decreased activity, that's going to lead to potentially increased weight gain because you're not as physically active, you're not out there burning calories to the same extent. In addition, if you are getting recurrent exacerbations and you're getting steroids, we know steroids increase your appetite, lead to weight gain as well. So potentially having poorly controlled asthma will lead to obesity. And there's actually been some studies out there that have shown that if you have children with asthma and they take their controller medicines and their asthma is well controlled, they're less likely to develop obesity. So clearly, if we can get the asthma under control, you're less likely to have this sequelae. But it also flips the other way around too, where there's some studies that have shown that being obese is more likely to lead to asthma development. And I just highlighted a couple here. Sorry, my little arrows did not apparently translate through, and that's why you're seeing random boxes. Maternal obesity has been associated with development of asthma in the offspring. So if mom is obese at the time of pregnancy, her kid is more likely to develop asthma. We also know that having adiposity or increased fat in childhood is associated with the development of childhood obesity, and prepubertal adiposity is also associated with the development of asthma in young adults. So clearly we see this interplay between the two. So I wanted to so now we know this kind of relationship where asthma affects obesity, obesity affects asthma. That's that superficial layer that I told you before. Now I want to go a little bit deeper and talking about how obesity can affect the asthma severity. And I'm going to focus on this long list. There's 3 that I'm going to focus on. I'm going to focus on the mechanical or physiological changes that happen in the lung, metabolic dysregulation, and altered inflammation. So when we think about obesity classically as a disease in adults, we see a restrictive pattern on our lung function, with the idea being that they have this increased weight on their chest and in their abdomen. It's pushing up, reducing their ability to take deep breaths. This is decreasing respiratory compliance and causing worsening trouble breathing at that point in time. However, when we see obese patients in children, they don't have that same lung function mechanics. They actually look like normal asthma. And there's partly a reason that this might be the case. And it's this concept called airway dysnapsis. So essentially, what's happening is in pediatric patients with asthma, their lungs grow bigger and faster than their airways can keep up with it. This leads to this mismatch between the two, where if you have big lungs, small airways, you get a reduction in your FEV1 to FVC, which causes obstructive symptoms that are consistent with asthma. And what's interesting is studies have shown that central obesity actually drives this development. So it's not just this concept of I have weight on my chest or I have weight in my abdomen that's pushing against the lungs, but rather the obesity itself is altering the development of the lungs and potentially in a permanent fashion. And there's actually been some studies that patients that have seen to have this airway development difference have worsening exacerbations, both severe and mild, as well as more frequent prednisone bursts than patients who don't have these kind of airway changes. The next thing I want to talk about is something called metabolic dysregulation. So this is this idea that if you're obese, you may have resistance to insulin. This could be a precursor to diabetes. And there's been good studies out there that have shown that having higher blood insulin levels in early childhood increase the risk of development in adolescence and adulthood independent of BMI. So it's not just all about weight, it's also about how your body handles your natural hormones, including insulin resistance. And there's some theories behind this. Part of it is that there's been some studies that have shown that there's been insulin receptors on the smooth muscle that's located in our airways. So essentially, if you are insulin resistant, your body starts making more insulin, it's not necessarily responding to it the same way. You're getting increased proliferation of the smooth muscles in the airway, and you're getting more contraction of those smooth muscles. So this is a way that just the insulin resistance alone could be exacerbating underlying asthma symptoms. Similarly, if we're thinking about this idea that insulin resistance leads to contraction of your airways, you're going to end up having worse lung function. And this was a study in adolescents, and they showed here, indicated by the green dot in the top corner, I don't know if I have a pointer or not, but indicated by the green dot in the top corner, that is a normal airway, normal patient, doesn't have metabolic syndrome, does not have asthma. The next patient down in yellow has a metabolic syndrome, and they have worsening lung function. The next patient has asthma, which has even worse lung function, but the patients that have both metabolic syndrome and asthma have the worst lung function overall. Finally, I want to talk a little bit about immune dysregulation, and this is this idea that even the immune system is different in patients who have obesity. I don't want to go too much in depth with this because it can get really nitty-gritty, but what I want you to understand is that the tissue that is in fat, the adipocytes and the monocytes in adipose tissue, they start producing a cytokine called IL-6, and IL-6 leads to Th1 inflammation. You may have heard about this today, you might hear about it over the course of the conference, but most of our drugs treat T2 inflammation. That includes steroids, that includes biologics. We're really good at T2 inflammation, but we're not great at T1. And our patients with obesity have more T1 inflammation. And this is going to be important when I start talking about the treatment strategies for this, because our patients may be resistant to these treatment strategies because of this. Interestingly enough, this leads to increased augmentation or survival of these ILC2 cells, which are also associated with allergic inflammation. So they're both going to have a predominant Th1 response, but they're also going to have allergic inflammation too. So they get hit in both sides. All right, and this is just showing that this IL-6, and I'm bringing this up because it's going to be important when we talk about treatment options, you can see you have low, medium, and high IL-6, and those patients who have an increased BMI produce more IL-6 or more of this T1 inflammation, and that's subsequently associated with more asthma exacerbations, worse lung function as well. All right, so this kind of puts it all together in terms of what happens to these patients that are obese, that it's not just mass, it's inflammation, it's underlying changes in their immune system. One other point that I just wanted to bring up really quick here, and hopefully it does not influence your lunch choices today, but high fructose has been associated with increased airway hyperresponsiveness and oxidative stress to the lungs. Vitamin D is often low in patients with obesity, and they may be a risk factor for obesity and asthma. And a high-fat diet has also been associated with these T1 inflammatory responses and worsening hyper-responsiveness. So please feel free to treat yourself, but also walk around outside. All right. So finally, let's move into this idea of treatment. So I want to focus on a few aspects of treatment today. One is there's these comorbid conditions that occur with obesity. You can have depression or anxiety, you can have obstructive sleep apnea, you can have worsening reflux. Those will impact your asthma control as well. So it's not just treating the asthma, but the conditions that go with the asthma. Then I want to talk very briefly that we use steroids, and I'm going to show steroids may not be the best responsiveness in kids with obesity, and then there's some new potential treatment options that are available. So this is just showing that, so I should take a step back here, that if you look at GINA and NHLBI and our guidelines, it still says that the primary treatment for patients with obesity is inhaled steroids, and you treat them the same step guidelines as anyone else. But there's been several studies done, and this is one of them, where they had patients that were non-obese and obese and treated them with inhaled steroids. And what I want to point out here is that the solid lines mean it was clinically significant. The faded lines show that it was not significant. So you may have had an initial improvement in your lung function in the obese patients, but it didn't last. And versus the non-obese patients, they had consistent improvement with inhaled steroids. This also shows that those patients who were treated with inhaled steroids, they did have a reduction in their prednisone bursts, but those obese patients did not have a reduction in their ER visits or their admissions, despite being on controller therapies. This study here, they gave kids an injection of triamcinolone and said, okay, maybe it's this idea that it's not just inflammation in the airway, but it's inflammation in the body, and we're going to give them triamcinolone, which will reduce that inflammation in the body. But even there, we did not see significant reduction in their asthma symptom scores or their albuterol use 7 days after getting a triamcinolone injection. So there's several reasons for this potential poor response with steroids. This low T2 inflammation being systemic versus local inflammation, these mechanical changes in the lungs. So what can we do? How can we really help these patients out? So here's our first question. I'll let you guys go ahead.
Yes. Very quick poll. Before we go to lunch, how fortuitous that we put you as the speaker before lunch. What percentage of hospitalized overweight or obese children with asthma had a documented weight management plan?
Okay, I'll go ahead and read off the results. 67% of us said 5%, and 26% of us said 8.3%, and 5% of us said 15%, and 2% said 12%.
All right, so our correct answer was 8.3%. So this is an opportunity for us all. When patients are admitted to the hospital, we should be addressing them as a comprehensive patient, the whole person, not just their asthma alone. And this is a great opportunity to talk about weight and how that it contributes to it. But only 8% of kids are having that discussion, and even if they are obese. And also, I don't want you to feel like we have to move mountains here to make a difference. These were adult studies, but they showed even a 5% weight loss can improve asthma control. So we don't need to make major changes to have significant shifts in our patient population. This is a summary of some of the more dietary or exercise-induced interventions that patients had. Like I said, in my clinic, we have a dietitian that works with us with these patients, and you can see that with weight loss strategies, they've had improvement of their lung function, improvement of their asthma controls, and even in the one study there, they saw a decrease of these inflammatory markers that I mentioned. So the last thing I'm going to talk about here is two kind of more experimental, more maybe where we're going in the future concept for asthma and weight. And that is the bariatric surgery and the GLP-1s, which you probably have seen everywhere. So there were studies done in adults with bariatric surgeries, and they showed that those patients who had bariatric surgery had about half of them were able to completely stop their asthma medications after their bariatric surgery, and another 20 to 40% had a reduction in asthma therapies. They did think that maybe some of these patients were misdiagnosed because it was so high overall, but it does show that that's a possibility for our patients. Interestingly, going back to this idea of inflammation, those patients who had persistent metabolic syndrome or persistent insulin resistance even after the surgery continue to have poorly controlled asthma symptoms. So once again, it's not just the weight, but the underlying inflammation and the way the body responds in terms of hormones. All right, and finally, I'll talk very briefly about these GLP-1 receptor agonists. They're designed to lower blood glucose by stimulating endogenous insulin secretion. They slow gastric emptying and reduces your food intake. But there have been some studies that have showed that they inhibit inflammation, that they might be involved with decreasing allergic inflammation in these patients, and also they might help actually relieve airway obstruction by opening up the airways more. The way that this data has come about is mainly retrospective reviews at this time. This was a study in adult patients where they essentially compared adult patients with diabetes and said, if you were on one of these other treatments, did it affect your asthma? And those patients who were on GLP-1s had better asthma control than with other diabetes medications overall. So there are studies right now that are going on that are going to explore this in adults in a larger population. We'll then eventually get to children, as with everything. And so this is maybe where we're going in the future. But I think it's really cool to see that these drugs might even have independent effects on asthma that are not necessarily directly related to weight. All right, so my take-home points for you all. I want you to recognize that obesity-related asthma is its own unique phenotype with its own unique mechanisms, that you have this dysregulation of the immune system as well as metabolic dysfunction. I want you to recognize that while guidelines-based therapy says that we should treat obese patients like any other patient, they may be resistant to some of the therapies we use, including inhaled and oral steroids. I want you to recognize that weight loss strategies in your patients can lead to improvement in their quality of life, their short-acting beta agonists, their asthma control, and their inflammation. And I want you to go home and have these conversations with your patients and realize small changes can lead to big victories. And finally, we may in the future think about bariatric surgery and these GLP-1 drugs for patients with asthma. And I might come back up here in 5 years and give you a talk and say, this is the standard of therapy, but this is where we're going. So with that, I thank you so much. This is our clinical team that I work with. And yes, I'm happy to answer your questions.
Thank you. Thank you so much, Dr. Anderson, for distilling all of that biological information in a way that really made sense and giving us some tips there at the end. So let's get a couple of questions. I'll start in the room this time since we started online last time. All right, who wants to go? I see.
Thank you. That was great. I was curious if you ever use any alternative measures to BMI, like waist circumference, because I know the distribution of the adiposity makes a big difference with metabolic syndrome. So do you ever use any alternatives to BMI?
Yeah, so I will say waist circumference is certainly one of them. We think about how the weight is distributed over the course of the body. This is something that I think in our clinic we're starting to explore more and more, but you'll actually see in the literature, as you're well aware, there's more data coming out showing BMI is not actually the best indicator. So while these studies focus on BMI, because that's what we've used thus far, I certainly see us in the future moving to different markers. And as you said, it's not just how much you weigh, but where the weight is distributed, how your body responds underlying at a biological level. We're going to see a lot of this moving ahead.
And let's take an online question.
Okay, hi, I'm going to read the online question. Is it possible that oral and inhaled long-term steroid use are inducing the metabolic syndrome and weight gain issues, or at least exacerbating them?
Yes. So we do know that oral steroids clearly lead to spikes in your blood sugar, can lead to weight gain, can lead to hypertension, can lead to all these terrible side effects, even with recurrent short bursts. It doesn't have to be chronic. There's also good data out there that even inhaled corticosteroids can contribute to these symptoms in patients, especially if they're smaller and younger, because it leads to a proportional increased amount or exposure to inhaled steroid. I don't want you to leave this talk saying, like, okay, I can't use inhaled corticosteroids on my patients, but I think it maybe gives even greater, makes you think more, do I need to be doing other therapies for these patients other than just jacking up their inhaled steroids? Do I need to be acting long-acting beta agonists? Do I need to be, instead of saying let's stepping up on your inhaled corticosteroid, let's talk about weight loss and get you on an exercise regimen? Or if in these extreme cases, do I need to be consulting with my endocrinologist about weight management?
Thank you. Thank you so much, Dr. Anderson. So we've concluded our morning portion of our summit today, And I don't know about you, but I learned a ton. Lots of great information about truly the effects of climate change. Hearing some of the recent data and some of the prevalence statistics that have been updated. Hearing about the interplay between obesity and asthma and different ways that we can think about treatment strategies and what we can do to surround our patients. I love what Dr. Marshall said is we need to take a step back sometimes and think, not what they're doing wrong, like what is it that are the barriers? What are the barriers and how can we think about things more creatively, differently, using common mechanisms but specific applications of solutions? So take that with you